the negativity is near the vertex of the head. You recall I was telling you that the Bereitschaft potential is fairly diffuse potential with a maximum at the vertex, and the NS dash continues this particular spatial distribution. As it gets a little later in its course, it sometimes lateralizes to the contralateral cortex, contralateral to the hand or the finger that is moving, but at this particular illustration, it's central. There is another inconstant component that one sees from time to time called the premotor positivity, or the PMP, which falls between the end of NS dash and the motor potential. That is an inconstant component, and I won't talk anything further about it in this lecture. Then we go on to the motor potential. And the very early part of the motor potential is diagrammed here. This is the recording of a single individual on multiple trials with the left index finger movement. And you can see that this is now the right side of the brain, that this negativity focuses very much into the right central region, contralateral to the moving finger. This looks like almost a somatotopic representation of where you would expect the hand area to be for the left index finger. Now, what I just showed you was a single subject. This is now an average of a number of subjects doing the same thing. And in this particular circumstance, you can see that here NS dash has lateralized a little bit over in this region, lateral, contralateral to the moving finger, and the motor potential is even more negative. Here, black is more negative than red. This is the highest negativity. This is the early part of the motor potential. Again, in this average group is clearly contralateral to the moving finger. This is now an average of right index finger movement. And in this circumstance, here's NS dash, again, generally around the vertex of the head. When we get to the early part of the motor potential, it is now shifted to the left cortex in the region of C3. So this particular component then seems to be related to the region of sensory motor cortex. The initial part of the motor potential, the very early rise, which is clearly before EMG onset, has this very characteristic focal appearance. And if one looks millisecond by millisecond in topographic maps, one can often see how this activity focuses or becomes more clear in this particular zone. Here's just one example of where it's relatively diffuse, and at 2 millisecond intervals you can see it focusing in this particular spot. And this is just at the very onset of EMG activity, or perhaps the order of 10, 20 milliseconds before. We wanted to get further detailed spatial information about where these components right at movement onset were coming from, particularly the different components of the motor potential. So in order to avoid spatial aliasing, we moved our electrodes closer together so that we could be absolutely accurate as to where the different potentials were coming from. This means that we don't get as much coverage of the head, but we can be more accurate as to where the potentials are really coming from. And this is a recording of multiple channels. Again, a left-sided hand movement with this recording montage. And here are examples of maps that we can make from such recordings. Again, this is a left-hand movement. This is the end of the NS dash component. We're now just recording from a small region on the top of the head. here's this relatively diffuse component, a little more lateralized to the right side, contralateral to the left finger movement. Here we have the first part of the motor potential, which is prior to EMG onset. And you can see this very highly focused component here around C4. That negativity, very highly focused, lasts for about 100 milliseconds. And we've called the end of that focused negativity the parietal peak of the motor potential, because of the drop-off of the negativity in the parietal area at that particular point. Subsequently, the negativity in the frontal region rises faster and goes on to what we call the frontal peak of the motor potential. This is the very highest point of the negativity in the movement-related cortical potentials. This is the highest point. It is after movement and has a distribution which is clearly anterior and more midline than the activity at the beginning of the motor potential. So if one looks at a cartoon of the negativity right around movement onset, what one sees is a relatively diffuse negativity, perhaps slightly contralateral, which focuses in the region here of C3 or C4, in this case C4. It lasts for a little while, and then the negativity posteriorly drops off, the negativity anteriorly increases, and one sees this negativity, the most prominent negativity of the entire recording, anterior and midline, or more midline. Now let me show you the results of a couple of interesting experiments that we did to try to help sort out where these different components might be coming from. If we make a similar recording of EEG activity and look at now an evoked potential, we take a ribbon, hold it onto the index finger and tug it in a similar way to which the person would be making a movement. In this case, there is no movement, there is no voluntary movement, but only a passive movement of the finger because it's being tugged. And it's being tugged in a similar way to which a person would do if he were making the movement himself. Now, in that circumstance, there is a standard evoked potential, and I want to draw your attention particularly to a negativity that one sees in this evoked potential, which is in the frontal region. And that comes at about 120 or 130 milliseconds after the finger tug. So it's a frontal N20 or so, if frontal N120. And it has a similar time from the tug and a similar distribution to the frontal peak of the motor potential that we see after EMG onset. So we believe that it is conceivable that this demonstrates that that particular component may well be coming from somatosensory feedback from the movement itself. Now here is a recording of a movement-related cortical potential in an interesting patient with a pansensory peripheral neuropathy. This is a very debilitating disorder, relatively rare, but comes up from time to time, in which patients get primarily sensory disturbances, sensory neuropathy, with very little involvement of the motor system. But all sensory fibers are involved, so that they have no light touch sensation, no vibration, no proprioception at all from the limb. And they become fairly ataxic because of the lack of any sensory input from the limb. In any event, they are able to generate voluntary movements. And this is the movement-related cortical potential on such a case. What is particularly interesting in this patient is, well, first of all, the recording is a little noisy, but one can identify NS dash and the initial slope of the motor potential, but there is no late frontal negativity in this case. This is topographic maps from this patient, and you can see that the initial slope of the motor potential is relatively nice. This is a left-hand movement. but the frontal peak of the motor potential, or as much as one can see of it, doesn't really move frontally and mesially. That particular component is absent. So here we have a patient who has no peripheral feedback, who seems to lack this frontal component of the motor potential, and we can get a potential that looks like the frontal peak of the motor potential after tugging on the finger. So it looks like this component may well be coming from sensory feedback as opposed to being related to the production of the movement in the first place. Now here's another positron emission tomography scan, and this time we've asked the normal subject to do repetitive toe flexion and extension. And as you would expect in this particular circumstance, the primary motor cortex for the foot is not on the lateral aspect of the hemisphere, but more near the top and on the mesial surface. And here is the mesial surface of the hemisphere, and you can see that the largest activation is there, where the foot area is. And additionally, there is some activity that's probably a little anterior to the foot area, which is likely to be the supplementary motor area related to the foot. There have been a number of studies now recording directly with corticography and in animal studies looking at the topography of the SMA, and what one sees is that the foot area of the SMA is more posterior than is the hand area of the SMA. The hand area is more anterior. So that what one finds is that the primary motor area for the foot is adjacent to the SMA for the foot, and then one has to go further forward to get the SMA topographically for the hand. So this mass of activity here is then on the mesial side of the hemisphere is a combination of primary motor cortex for the foot and SMA for the foot. And here's a recording of premotor potentials from the foot. And this is what it looks like when one does topographic mapping. NS dash is central, and at the very beginning of the initial slope of the motor potential, we're now still at the vertex. It does not lateralize. It stays right at the vertex region, and this is now before movement onset. And this is what happens when one is, this is at the first part, when one is moving the toes, the frontal peak of the motor potential moves slightly anterior, but only very slightly. So it doesn't change terribly much from the initial slope of the motor potential. Here's a direct comparison between movement of finger and toes, and at the time of the initial slope of the motor potential, here with the ISMP, the initial slope is over C4, where for the toes it's over CZ. And this is at the end of the motor potential, or the parietal peak of the motor potential. With the frontal peak of the motor potential, now after movement, about 120 milliseconds after movement or so, this particular potential, which is probably this reafferent one, is anterior to what one sees for the toes. The toes are here and the foot is up there. So what one can see, therefore, is that there appears to be a topographic mapping of these different components. The initial slope of the motor potential being relevant to where motor cortex is, and the frontal peak of the motor potential being where SMA is. That's what seems to be the case from just this kind of analysis. Now, I'm going to make this part of the story extremely brief, but we have been doing recently some dipole analysis of these particular potentials to try to get some sense from a computational point of view, looking at this data that we've been collecting, where these potentials might come from. And doing dipole analysis is a little tricky, and I won't bore you with all the details, particularly given the time. And I'll go on to what dipole sources we have identified for the waveforms. One particular spot that we have chosen is to look at the time of about 120 milliseconds or so, which is the time of the frontal peak of the motor potential, and obtained its dipole in an average group of subjects. And this is using the so-called BISA program, which is commercially available from Neuroscan. This isn't a product of our own. In this particular circumstance, one has a dipole which is relatively close to the midline but somewhat contralateral, and you can see its distribution here in these different projections. This is the way the dipole looks in terms of its negativity and positivity on the surface of the scalp. And this particular dipole can be seen to dominate and explain much of what's going on in the movement-related cortical potentials for tens of milliseconds around this peak. So this is a very dominant peak at this particular moment. Now, if one looks earlier on, and here we're fitting at about minus 86 milliseconds at this particular point, one can't find a single dipole that will fit well, but there are two dipoles that fit, and in this particular model we have constrained these two dipoles to be in symmetrical places in the two hemispheres. One winds up with dipoles that look like this, that are more laterally placed than that first dipole I showed you, and could well be sitting in the ipsilateral and contralateral motor cortex. These dipoles can explain most of the activity just before movement onset. So what I've been showing you is that there is good reason for thinking that the activity just before movement onset is coming from primary motor cortex. It is somatotopically related, and with this dipole analysis one can show that the activity is likely to come from there. And just after movement, one sees activity that is more midline, coming from a dipole that's a little further forward and may very well be supplementary motor area related. So those things being the case, it looks like then we can get a probe of activity from these parts of the brain. Now I go back to the PET scans, just to make sure that we understand the sort of analogies that I've been trying to draw here. I've been showing you in the PET scans that there are two very active areas in cortex when one is making voluntary movements. There is primary motor cortex and there is supplementary motor area. And we can see from the analysis of the movement-related cortical potentials that we can explain most of it by potentials that appear to come also from these two regions. The PET scan then gives us information about where it is, and we think that the movement-related cortical potentials will tell us the timing of this type of activity. Now let me show you a couple of examples of how these things fall apart in different disorders of the motor system. This is going to be a little story about congenital mirror movements. There are patients who are born with a disorder of the motor system called congenital mirror movements, where when they try to move one hand, they will wind up moving the other hand as a consequence in a mirror format, so that if they're writing, for example, with one hand, they will wind up, if they have a pencil on the other hand, writing in a mirrored format the same thing. This is older methodology for doing positron emission tomography. This was in a normal volunteer. I won't bore you with that for the moment. This is in our patient with congenital mirror movements, and what one sees very prominently in these patients with the PET scan is that both sides of the motor cortex appear to be roughly equally active. Not like in the normal that I've showed you where the contralateral motor cortex is very active. In this circumstance, both sides of motor cortex appear to be very active. Now what do you see in the movement-related cortical potentials? Here are all the potentials there, and I'll summarize them for you in these topographic maps, what one sees, the NS- component is again generally diffuse at in the region of the vertex, nothing particularly abnormal there. But at the initial slope of the motor potential, rather than lateralizing well to the side contralateral to the wheeled movement, what one sees is a much more generalized potential, suggesting a wider, broader activation of the motor system. Now, in particular, let's look at what happens on a millisecond by millisecond basis, and this is sort of interesting. If one looks at the intended movement of the right first dorsal interosseous muscle, just before the movement in the right dorsal interosseous muscle, there is a focus, there is the highest negativity in the region of C3 on the left side of the brain, contralateral. The movement of the left hand occurs very shortly thereafter, and at that moment, which is about 10 milliseconds later, this has become more generalized so that the peak of the negativity is now in the midline. It looks as if the negativity begins properly on the left, but then doesn't focus on the left, instead remains active throughout and spreads across to the other side. This is the sort of information that one can get on a millisecond by millisecond basis looking at this kind of information, and may give some sense as to what's going on in the brain as these patients make their abnormal movements. Now let me tell you a word or two about two other circumstances relatively quickly. The first is Parkinson's disease. Parkinson's disease is a disorder in which movements are very badly abnormal by virtue of being slow, weak in force, and a variety of other things. And people have been studying these movement-related cortical potentials in Parkinson's disease for some time, trying to make some sense as to what they could be telling us about what is going wrong in Parkinson's disease. One of the problems has always been in interpretation of this data is that the sources of these movement-related potentials have not been clear, and hence the interpretation of the abnormalities has been confused. In any event, I think that most people now believe that the Brightshoff potential, that slow negative component, is in fact abnormal in Parkinson's disease. This was a matter of debate for a long time, and one of the problems was that it turns out that the Brightshoff potential component is very sensitive to a number of things. It is sensitive to DOPA dose, and whether the Parkinson patient is on or off. So if the patient is getting DOPA and is doing relatively well, the Brightshoff potential is higher, and if they're off DOPA and not doing so well, the Brightshoff potential is lower. It also is the case that the Brightshoff potential tends to diminish with age, and a number of the early studies didn't properly match patients for age and got somewhat confused in that regard as well. This is just a quick example to show how the amplitude of the Brightshoff potential changes whether a patient is on or off L-DOPA. Here, for example, at the recording at CZ, the Brightshoff potential here went off, clearly shows less negativity than went on. When one takes all of these things into account and has the patient properly medicated and whatnot, is the Brightshoff potential abnormal? And there is a feeling now in the most recent study by Dick and others in 1989, this is from the Marsden group in London, that there is in fact an abnormality of the Brightshoff potential, so that it rises slowly here, but eventually picks up, so that by the time that one gets to the peak of the motor potential, it is now normal in amplitude. The interpretation of this is not yet quite clear. I show you these as facts, but I must say I don't quite understand how this comes about. One of the difficulties that I have is that I'm not completely sure yet where the Bereitschaft potential itself is coming from. I've given you a great deal of information, which I think seems to be true, about these components right around movement onset, but the Bereitschaft potential itself, this slow negativity, is still a little confusing to me. Let me show you what happens to the components right around movement onset in patients with Parkinson's disease. And this is such an example on this slide. This is the right and the left side of a patient with hemi-Parkinson's disease. Let's just look here at the top. This is the initial slope of the motor potential with right-hand movement, the initial slope of the motor potential with left-hand movement in a patient with very bad Parkinson's disease on the left side. You can see that the topography of the motor potential here is fairly good, but that it falls apart over here. It becomes much more diffuse. And that's one of the things that one can see in this particular circumstance. Additionally, and let's look down to this recording over here, for example. The frontal peak of the motor potential in these patients is also not quite normal. This is on the more normal side, and sorry, in this circumstance, this is a different patient. This is the more normal side. You can see that the frontal peak is moving anteriorly here, but in this circumstance, it's remaining more posterior. It does not move forward as it should. And what we're interpreting this kind of finding to mean at the moment is that there is less discrete activation of the motor cortex prior to movement, and that there is not as good activation of the SMA following movement, that is in some way deficient. And in fact, it has been demonstrated in evoked potential studies. As you perhaps know, Rossini and colleagues have reported in Parkinson's disease a diminished amplitude of the frontal N30 component, which they believe correlates with Parkinson's disease and may reflect a similar kind of abnormality to the failure of the frontal peak of the motor potential to move forward. Similar types of abnormalities are seen in patients who have cerebellar disorders. In fact, it's very similar indeed. Here is a comparison of average of normal subjects and patients with cerebellar diseases. One sees here the normal subjects, the initial slope of the motor potential for a left index finger movement is highly focused. In the cerebellar patient, it's not so well focused. And the frontal peak of the motor potential in the normal subjects moves anteriorly, and in the cerebellar patients, it doesn't move so far anteriorly. So one sees a similar type of abnormality, a less strong activation of motor cortex and a less strong activation of supplementary motor cortex, presumably if one can believe this type of information. Currently, we are doing positron emission tomography in these patients as well to get some sense about activation of different parts of brain in these same subjects. Well, it's hard to explain how the brain works in making voluntary movements. We and of course many other people have been sort of struggling with this problem for a long time. I think we're beginning to make some sense now of where these movement-related cortical potentials come from. One can begin to get some information in different motor disorders how these potentials are falling apart, which may tell us something about the pathophysiology of the condition. In relation to clinical work, I think it's a little premature. to get involved with this at the moment. There are potentials here. Sorry, that's sort of a pun, isn't it? There is the possibility of eventually using tools like this to study different types of problems. For example, the amplitude of the Bereitschaft potential may be a good measure of the quality of treatment of a patient with Parkinson's disease. It may be in other circumstances that one may be able to do diagnosis by, or help out with diagnosis by finding a particular abnormality in a patient with a different movement problem as to what's going on. But I still think at this point it is a little bit premature to use these in the clinical laboratory, but you can see where we are with the state of the art at the moment. Thank you.
The contribution of brain stimulatory evoked potential studies in MS is less spectacular than of the visual evoked potentials and somatosensory evoked potential studies, especially of the lower limbs, because it's a longer tract. The indication for doing brain stimulatory evoked potential studies in patients suspected of MS is when there are definite lesions outside the brainstem, and we are looking for another unsuspected lesion. And then, of course, if we can gratify the referring neurologist with the result of a BAEP abnormality, he's happy because he has an unsuspected lesion. Does it make sense to inform the neurologist what he knows already, namely that there's something wrong with the brainstem when he knows this, and you have a definite case of MS. In this case, on one hand, he knows this is MS. On the other hand, you reduplicate his information. It's interesting to know that in a large series of 466 patients, 40% or so showed abnormalities on brain stimulatory evoked potential. But this percentage varies between 21 and 50. And the reason for this variation is the use of different techniques, the uncertainty about this Mach Alpine definition, if it was a probable or possible or definite MS, and the patient population that they studied. In brain stimulatory evoked potentials used in diagnosis of MS patients, there is no definite abnormality to speak of, since the lesions are scattered by definition, sclerosis in plaques. The upper pons can be involved, the lower pons can be involved. You can have wave 5 missing, or here, in an extreme case, you can have all the waves missing except wave 1. Okay. And here, it's an interesting slide showing what I try, perhaps succeeded, to convince you that if you don't find anything wrong when you do 10 per second repetition rate stimulation, it's nice to use another repetition rate. And in this case, the author used no less than 80 per second repetition rate, and so a definite interpeak latency abnormalities for 1 to 5. Of course, 80 per second is exaggerated, but at about 40 per second, you can see already abnormalities. And this is a table which was from Chiapa, in which is a study of definite, probable, possible, and total evidence of clinically unsuspected lesion. And BAR alone made diagnosis in 4 definite, 6 probable, 5 possible, total of 15. While the VER alone did it in 61. But here, in this picture of unsuspected lesion, it's interesting to see that BAR are better than SCPs. And what can be the reason? Most of the patients are coming with symptoms in the somatosensory area. So when you come with a surprise that BAP show abnormality, of course, this helps a lot the referring physician. The area of greatest success diagnostically of the BAEPs is no doubt tumors, and especially cerebellopontine angle, CPA angle tumors, and especially acoustic neuromas. 6,000 acoustic neuromas were studied, and until very recently, I say very recently, there was no negative study when acoustic neuroma was proven to be there. In acoustic neuromas, the BAP can compete with great success with the MRI, because if the acoustic neuroma is a very small, will not be captured by the MRI. By the way, you heard probably before that in MRI you cannot have a total superiority over BAPs, or no, evoked potential generally in MS either, because in MRI you can have lesions which could be very well vascular or demyelinating lesions, while in evoked potential studies we have the evidence of demyelinating lesion. Very interesting example. It's a patient with a 50 millimeters acoustic neuroma. The pure tone audiogram showed deficiencies with speech discrimination 48%. A recorded at 60 dB sensory level, B at 45. Wave 1 was poor resolution. And finally, in B, you see that the 1 to 3 interpeak latency is abnormal. The CAT scan in this case was perfectly normal, but an acoustic neuroma was found based on interpeak latency delay between 1 and 3. I'd like to bring to your attention that a lot of studies are based on delays of wave 5, but the most characteristic abnormality in an acoustic neuroma is a delayed interpeak latency 1 to 3, which you see here. Another case of acoustic neuroma and normal CT scan. 1 to 3 separation is the upper limit of normal, but the inter-ear difference is greater than normal plus 3 standard deviation, and so you confirm the abnormality. This is again an acoustic neuroma which was demonstrated by BAP but missed by the CT scan, we proudly say. And here you have all kinds of abnormalities, from an ear ipsilateral to a confirmed CPA tumor. You have here nothing but the cochlear microphonic. You have here only wave 1. In this case, there are 5 patients. The third patient has wave 1 and 2, nothing else. The fourth patient is not in possession of the wave 3. And this is the best case with the best prognosis. Acoustic neuroma, extremely large, is seen here, and is wave 1, and no other defined, clearly defined waves. Large acoustic neuroma. And here is pre-op and post-op. It's a little obscure. It's an old slide, with historical value, and you see how everything improved post-operatively in an acoustic neuroma. This is a brainstem glioma. At the time of testing, the left corneal reflex was absent. There was numbness of the entire left face, and the jaw deviated. And there were abnormalities compatible with the tumor. And the diagnosis was made by BAEP. However, if a large tumor is not attached to the cochlear nerve, CAT scan can be more productive than BAEP, and BAEP doesn't do too much. You must have this in mind as well. These are children with left pontine glioma. One case, another pontine glioma. It's just to show you the variety of abnormalities happening, especially missing waves in CPA tumors. This is a moderate size acoustic neuroma where interpeak latency 1 to 5 is delayed, because attention should be paid to even minute changes which can determine the severity of disease. It's a very sensitive test, but attention should be paid, as I said, even to the latency delays, which don't have to be spectacular. Okay, here is a case when wave 5 is delayed contralaterally. And as I tried before to convince you, there are only ipsilateral lesions in testing brainstem auditory evoked potential. But here, probably because of being so large, there are contralateral to the tumor definite abnormalities, morphological, which cannot be quantitated unfortunately yet, and especially missing waves and delayed latencies. Okay, before going to a new entity, I want to tell you again that, however, there is a study in 1991 reporting in 56 patients that brainstem auditory evoked potential were normal in kind of 10%. However, acoustic neuroma was found in these cases. This is the first time that such occurrence is reported. Brainstem auditory evoked potential studies are helping the diagnosis in vascular problems, like in a TIA. Recurrent TIAs of the vertebro-basilar arterial system, showing abnormalities in terms of latency delay. Amniotic embolism affecting the brainstem, and matching a locked-in syndrome, pinpoint pupils, ocular bobbing, absence of corneal reflex provided evidence of the brainstem lesion, and correspondingly, you have no waves 3 and 4 and 5. Of course, Dr. Gliblin will tell me, we knew already that something is severe here, you don't need. But why shouldn't you have an objective evidence? Okay, strokes with full recovery and a recovery also in the way the brainstem auditory evoked potential look. These are severe conditions, asphyxia reported by Hickox, and these are metachromatic problems, normal A's, metachromatic leukodystrophy with all severe problems, severe abnormality of the BAEP. This is the brainstem auditory evoked potential in a progressive adrenoleukodystrophy from the beginning to the end, with a totally deterioration of the waves, and the patient, of course, deteriorating similarly and deceased. Alcoholism. Begleit and Porges in Brooklyn, it's a nice area in New York, did a study in alcoholics, chronic alcoholics, and found delays. Now, delays in the interpeak latencies in alcoholics can be attributed to the fact that you have a lowering of the body temperature, which I said is present. And this can explain the findings. There are, however, findings in long latency potentials which cannot be explained. It's a recent study showing delay in long latency potential, the late potentials, in alcoholism. And here I have another example, if I'm not wrong, but who can see it, of alcoholism and a lot of delay in the peaks. Another condition is prematurity, a neonate, 37 weeks gestational age with abnormalities in the auditory evoked potential, brainstem type. Deaf child, age 6 months, 110 decibels and 4 kilohertz burst. No, this is clicks, nothing. Severe cases of asphyxiated neonates and infants in which is a destruction in different degrees. This is a better looking and this is nothing. Other infants with all kinds of problems. In severe hearing problems, which the wave 5 recognition test failed because wave 5 disappeared before 35 or 30 decibels, which shows the severity of deafness, and no wave 1, of course. This is a case of sudden death, but there is a near-miss sudden death syndrome. There was a lot of enthusiasm, especially from the Cleveland Clinic, when the sudden death syndrome started to be recognized, with very encouraging papers saying that the BAPs will be abnormal. But then Stockard had a bad experience, saw a child, BAP is normal, child died after a few hours. Crib death. Here are, however, some findings in a near-miss sudden death syndrome in children. And, you know, associated with this is the apnea in children. This is a spiral ganglion in the concept of Satyamurti, reproduced in the book by Moguer. And this is a kind of equivalent to the posterior dorsal ganglion, spinal cord. And the diseases which are produced by problems with this spiral ganglion are such as Charcot-Marie, tooth. And this is a unique slide. I don't remember where I took it from. It's difficult to find the reference. But it shows clearly hereditary motor sensory neuropathy type 1 in a 12-year-old male with a prolongation of the latency of all BARs, but especially the 1 to 3 interpeak latency, and especially because of the separation between wave 1 and 2, the proof that auditory nerve is also delayed, like in a proximal neuropathy. Well, this should be a case of Alzheimer's disease, but you don't see it well. We finish now the brainstem auditory evoked potential with a clinical application. We go to the middle latency responses, a very much neglected area. Middle latency responses are between 10 and 60 milliseconds, and this, you see them recorded from a normal hearing adult. This is a picture of brainstem auditory evoked potential and middle latency responses. To see the spectrum for 0 to 60 or 70 milliseconds. They are called NO, PO, NA, PA, and so on. This is a unique, there are two cases in the literature, one by Nina Kraus, Özdamar and Kraus, and other by Graham, where cortical deafness revealed a total absence of the middle latency responses, while the brainstem auditory evoked potential, which are small here, you have to look, are present. The middle latency responses are in competition with the sonomotor responses. There's so many myogenics in the neck. Therefore, when you put the neck in tension, you cannot see the middle latency responses. When the neck is resting, you can see them. The sonomotor responses were used as a hearing tool. They are inion, temporal, frontal, PAM, posterior auricular muscle, described by Bigford 665, if I'm not wrong. And you see here a deaf child, where in spite of the deafness, the inion response is still there, while the mastoid is gone on the affected side. This is a description of a few sonomotor or myogenic responses. The PAM, which is now a vestigial muscle in men, responds to a frequency of 10 to 20 hertz. And what is terrible, does not disappear with the relaxation of the neck muscles or any other muscles. So remain a nuisance. They are recorded from the ipsilateral mastoid, unrelated to muscle tension, can be bilateral, unilateral, great variability, and so on. And the temporalis, the frontalis, the neck muscles, all have characteristics and have to be taken into consideration. Now we arrive to a crucial moment and we speak about the oldest potential, the slow cortical potential, which was seen by the husband and wife Davis in 1939, and then in 1963 by Yoshi and Davis. They were proven that they are what they saw before, because they have this time the averager at their disposal, computer averager. And this slow cortical potential, which is high as 15 microvolts, which is remarkable, is made of four potentials: P1, N1, P2, N2. P1 is more of a hearing threshold. The other ones are used in neurological research and so on. But you'll see it's not so simple. They are used also together with P300 in doing studies in schizophrenics and other categories. Such a study was done in 1986 when, together with the P300, which is the area of Dr. Spielholz, and I'm not going to go inside too much, and the N2 and P2 of the slow cortical potential were studied in three groups of patients: Parkinson's, Huntington, and Alzheimer. Also the family of Huntington and Parkinsonians not attempted in a very initial stage. It was realized, surprisingly, that the two dementia which are associated with subcortical lesions, namely the Parkinson, where still substantia nigra seems to be the place where it takes place, but according to Dr. Eisen, they must be in the brain as well. We don't have an evidence yet. and Huntington were much more severe in the delay of these potentials than Alzheimer. And between the Huntington and the Parkinson, Huntington showed more severe delay, especially for P2. Now, I just want to remind you what you'll hear extensively and superbly from Dr. Spielholz, the P300. It's another entity I want to entertain you about, which is extremely interesting, and in view of the fact that Dr. Mark Halley just spoke about Bereitschaft potential, it's even of more interest. This is called contingent negative variation. It's a negative shift described by Walter after 66, something like this, and defined as an electric sign of sensory motor association and expectancy in the human brain. The paradigm is made of a warning signal, followed after a few seconds by an imperative stimulus to which the patient has to respond. In audiometry, they use a light. First, the patient hears a sound, and when he hears a sound, the gentleman who does the test, or the lady, tells him, now after this sound you will see a flashing light, and you will press a button and the flashing light will stop. This is an expectancy test, because what determines the CNV is the fact that the patient is expecting the flashing light to show. And if the flashing light will not show, you will still see in many cases. It takes time until you establish the test. A slow negative potential develops between the auditory potential produced by the warning sound and the visual potential resulting from the flashing light. And you have to be careful to distinguish this potential from the readiness, excuse me, or Bereitschaft potential, also from involuntary eye movements, especially when the patient looks down, rolls his eyes downward. The CNV starts 400 milliseconds after the warning stimulus and ends with the imperative stimulus presentation. So, expecting the imperative stimulus is all the reason, la raison d'être, the reason to be of this potential. Excuse me. It seems that CNV is a result of summation of 2 or 3 waves. A stimulus-related negativity, mostly frontally, is possibly related to the orienting response when you explain the patient what to expect, and followed by, excuse me, centrally predominant negativity considered to be related to the premotor potential. See, think of Bereitschaft is also a motor type of potential, associated with the motor response. A shorter reaction time increases the amplitude while drowsiness decreases it. So it's another test which could be very helpful in psychiatric problems, but is used mostly in audiological tests and the measure of hearing. There is another potential, sustained potential, and there is a galvanic skin response, but they are not clinically useful at the present. Therefore, I just want to end by saying that brain stimulatory evoked potentials are used exhaustively, and possibly more research and more attempt afterwards of clinical application should be done for the longer latency potentials. Thank you for your attention, which was in a trial with my 2 lectures. Thank you.
This is an area that is loaded with terminology, and a lot of it really turns out to be the same. So just to give you some idea of it, people have been calling this thing, this P300 or cognitive evoked potential, a cognitive evoked potential, an event-related potential, a task-related potentials, endogenous potentials, stimulus non-specific potentials, very long latency potentials, and finally P300s or P3s. Just as the literature evolved in this field, people were giving it different names, and then it was found out that many of these things really mean the same thing. So fundamentally, it's not that all of these things are different. They're really basically the same. And what I'd like to do is explain a little bit more detail what some of these names mean, and then we'll go into the paradigm for recording these cognitive evoked potentials. A lot of this area makes more sense once you understand a little bit about the equipment that is needed and basically what the subjects are asked to do. Just one thing about these so-called evoked potential categories. Sometimes people divide these up into the exogenous and the endogenous, and those names have come up every once in a while. So just that we understand what is meant. And an exogenous potential generally is determined by the sensory characteristics of the stimulus presented. By that it means an exogenous potential would be, for example, the somatosensory, when you use a specific stimulus of electrical shocks, an auditory or a visual. In other words, basically, these things are stimulus specific. As far as we know, they are received by specific receptors, and they are carried with a relatively short latency, relatively speaking, to specific regions of the brain. All right, so they are exogenous because they come from the periphery and basically are brought in, received by specific receptors, and then go to a specific part of the brain. Endogenous potentials, on the other hand, reflect the subject's cognitive reaction to the stimulus presented. In this case, the subjects are told about, basically the subjects are instructed, and depending on what the instructions are, how they react now to the stimulus, all right, is the next stage. So these are the endogenous potentials, whereby the subject is following a particular strategy, so to speak, in order to make a decision about the stimulus. So it's not the stimulus itself, it's a reaction that the subject is told that he does or doesn't make in response to the stimulus. These stimuli are usually called stimulus nonspecific because, as you'll see, you can record these P300s in response to either auditory stimuli, somatosensory, or visual, and indeed we'll even tell you that if the paradigm includes an absent stimulus, that can also generate a response. And you'll see, I think, what I mean as we go more along with the paradigm. So if you can get a potential from the brain in response to an absent stimulus, all right, then this is really stimulus nonspecific. So these are basically reactions that now occur after the brain has processed the original stimulus, which would be an exogenous stimulus of some sort, but then the brain makes a decision based on that stimulus, depending on a particular paradigm, and then you get a potential generated in response to that reaction. So this is why these things have been called endogenous. I hope that makes sense. A P300 is the brain's response to an unexpected or rare stimulus among a string of frequent stimuli. And I'll explain to you what the subject is going to be told how to know whether it's unexpected or not. The subject generally must be actively attending to the stimulus. Dr. Lieberson 2 days ago told us something about P300s in response to somatosensory, where he said, the subject really wasn't particularly told that they have to be actively attending to the stimuli. In the paradigm that I'm going to be telling you about, the subjects are told and they have to be cooperating with you, so to speak, in that they have to be listening or concentrating on something. And it has also been shown that the more difficult the discrimination between rare and frequent stimuli, and again we'll define what we mean by rare and frequent, but the more difficult the discrimination, the longer the P300 latency. And so you see, you can start to play a lot of interesting games with this P300 paradigm, because if you make certain discriminations more or less difficult, you can change latencies. Because of this, usually most of these studies are done using auditory stimuli, because auditory stimuli are basically easier to control, so to speak. And we'll go over this a little bit more. Another way to look at this is that the cognitive evoked potential is a vertex positivity. It is usually recorded at its largest amplitude at the vertex, or sometimes it's called a vertex positivity, generated when the subject recognizes a change in an ongoing stimulus pattern. Since the subject recognizes a change, and this is the so-called target, this implies that the brain is actively processing or attending to the stimulus and then makes a decision about the stimulus. That's basically what I was just saying. The CEP is stimulus nonspecific because it doesn't matter what the actual stimulus is. It can be auditory, visual, or somatosensory. What's important is the change, that the subject recognizes this change. And this is why the CEP is also called an endogenous potential. It's also called a decision potential. It is not generated by the receptors or pathways as far as we know. And Terry Picton, who is sometimes described this as the aha potential. It's, when the person says, aha, that's what I was supposed to listen to. Now, the paradigm then goes something like this. Let's take this situation. The subject is explained that you're going to be putting earphones on, and they're going to be hearing certain tones coming out of the earphones. The tones are applied binaurally. This is not a situation where you put masking noise into one side and clicks into the other. Basically, you tell them you're going to hear two different tones. And the reason why I use tones is that if the frequencies of these tones will determine their pitch. Right? And the further away these are in frequency, the easier they are to discriminate. So, for example, if you have your device set up such that you deliver tones of, say, 1,000 hertz and 2,000 hertz, or that would be their, the frequencies, the pitches are going to be fairly well separated, so you can make the discrimination relatively easily. If you make the frequencies of the tones closer and closer together, let's say 1,000 hertz versus 1,100 hertz, all right, then the difference between the tones are more difficult to tell, right, so it may take a little bit longer to make that type of a decision. That's why I said that it's easier to use auditory stimuli because you can play more games. So, for example, you would tell the subject that they're going to hear two different tones. One tone is going to appear relatively commonly and often. This is sometimes called the frequent or the non-target. Right? So, for example, you tell them they're going to hear a tone that's going to go something like beep, 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 very monotonously. Every once in a while, in a totally random fashion, the tone is going to change. It's going to go higher, let's say. That will be the target or the rare tone. And what they're supposed to do is listen to these tones, and whenever they hear the target, right, or the rare tone, either they count it to themselves, or some people actually have them do a button press. I try and stay away from the movement because I don't want to, basically generate some sort of a movement artifact or one of these other things that Dr. Hallett was talking about. But it works just as well if you simply tell the subject, when you hear the target, count it to yourself. And at the end of the run, all right, we're going to ask you how many you heard. All right, so the ongoing stimulus train is the frequent, and then the unexpected, because they never know when it's going to come in, all right, is the rare or the target. Now, in order to discriminate between the two, what you now need is a machine, well, first of all, that is going to be able to generate these different tones, but then you have to separate or segregate the evoked potentials, all right, that came following the frequency, and they have to be averaged separately from the EEG train that followed the rares. So that's one of the extra added attractions that you have to have on your machine. All right? Basically what this implies is that for each channel of recording, you have to have two averages. One that's going to average the frequency and one that's going to average the rares. So basically you just can't use any old evoked potential unit, because you have to be able to separate the frequency from the rares so that they are averaged differently. The other requirement that people usually talk about is that within this train that you're getting, the frequencies occur something like 85 to 80% of the time, and the rares occur either 15 to 20% of the time. So the rares are really occurring infrequently, right, and the frequencies are occurring, the majority of the time. Now, another technique that is frequently used on this, and this, by the way, is taken from, I believe it's from Chiappa's book, is a demonstration of the rows of averages, the two different ones, taking the frequency and the rares. And the technique usually is that you record from three midline positions. Even though it's usually a vertex positivity, people generally today like to make at least 3 recordings from the scalp, basically an FZ, a CZ, and a PZ. These are usually referred either to linked ears or to one ear. So the reference, let's say, is A2 or A1. And usually a fourth channel is used to monitor the EOG. As Dr. Hallett indicated in some of those other studies, you want to make sure that the eyes aren't moving, because, again, eye movement can produce potentials over the brain. So basically, you also have a fourth channel recording ocular movements in order to show that there is no extra movement, let's say, in response to the rares than there is in response to the frequency. And what you're seeing here now are segregated frequent and rare channels. And in this case, I think it was indicated that in this case, the frequent tones were 1,000. That's very common. The rares are 2,000. So that's a nice separation of tones. And this particular case, I think, out of 100 repetitions, the rares occurred 16 times, and the frequency therefore occurred 84 times. It's usually in that type of a ballpark, right? Roughly, say, 2080 or 1585, that type of situation. The interesting thing is that these potentials then basically can be recorded just in response to what are fundamentally 15 responses. These are usually pretty big potentials. These things measure a good number of microvolts. Now what we're looking at here, again, these are repetitious runs, showing repeatability. And basically what you see here, in response to the frequency, right, you do get some earlier potentials, sometimes in this case called the N1 and a P2. With this N1 is about 100 milliseconds later, so we're looking at things way after the brainstem auditory. Right, this is the overall sampling time here can be anywhere from 750 to 1,000 milliseconds. So you're really sampling out over a relatively long amount of time, which obviously is going to cut down your repetition rate. Because let's say if this is 1,000 milliseconds across, you may have these things being presented, say, once every 2 seconds or something like that. It's a lot slower than you're used to doing with brainstem auditories. But basically what you see here very nicely is that in response to the rares, these peaks over here are the P3 or the P300. You do not see them in response to the frequency, but in response to the rare, to the aha, that's what I was supposed to listen to, all right, you are generating this type of positivity. And basically what you see is that you can usually get them over all 3 recordings anyhow, although in general they tend to be larger either in the central position, the CZ position or the PZ position. They can be recorded frontally, obviously, but usually the frontal is a little bit smaller than the others. But fundamentally, you can use any of these. Many times, the rare is also a subtraction curve. You can have the machine actually subtract what this one was like from what this one was like, and then this is really the end result of that overall subtraction curve. Some people do not bother subtracting the frequency from the rares, some do. We have been doing, we've had our computer program that it will then do the subtraction of them. it seems to accentuate basically the P3. Now, the things that have been looked for here, fundamentally and mostly, has been the peak latency of P3. All right? And okay, so that's your general paradigm for it, and this is just something from our own biologic, again, in response to the frequents, in response to the rares. We're just using a different machine. That's no big deal. Now, people have looked at this under a number of different circumstances. They've looked at that these P3s in response to using the variables of age and task difficulty. And not surprisingly, one of the things that was found, this is a Gooden and Starr people, Ken Squires, Nancy Squires, a number of people that have been working on this. And one of the most obvious changes that occur with the P3 is the response in aging. And this is from, I think, from Gooden, one of Gooden and Starr's papers, and then basically showing in different age groups, and then we'll show you the regression line later, 15, 27, 35, et cetera, et cetera. If this is the average value where this dashed line is, as you see, as we get older and older, except, of course, for Dr. Lieberson, this response comes out later and later in time, so that fundamentally, by the time we're about 80 years old, this thing can now be out at around 400 milliseconds. And people believe that this is part of the overall slowing down process. We don't just get slower, in our movements. We know we get slower in decision making, and it has been shown to occur with the P300 as well. If you, this was from a study that they did, Gooden, Squires, Henderson, and Starr, but in a chapter that I wrote, Aging, that they wrote in a book or something, Aging in the 1900s, basically it just shows you this type of a regression line. It's interesting, if you, I think, what is the youngest age here is something like 20. I think I indicate in my handout that other people have looked at some of these things even in earlier time, and there are some other interesting dips that occur even before the age of 20. But once we hit 20 and then start to age, these things do start